Blog Talk Radio. Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yadon.
And thank you, Braley. Hello, everyone. Today is Tuesday, August 7th, 2012, and welcome to the Medicaid Matters talk show. For the next hour, you are going to be introduced to some of the most insightful, interesting, and entertaining conversation about Medicaid health care that, frankly, can be found anywhere in the industry. And that's not a claim I'm making. Over 11,000 of you have chosen to join us regularly, so we must be doing our job right here. I'm glad you're with it. I'm Richard Yadon, President and CEO of Managed Medicaid Services and the host of Medicaid Matters. And today we have a very interesting topic. I can see that we've already got a lot of people joining us, and I'm not surprised. I'm very sure that this topic and our show today would gather a lot of interest. You know, the Supreme Court has made its ruling, and unless something dramatic changes in November, the ACA is now the law of the land. And I've had a lot of you from our audience asking me, hey, what do we think about this? What are we going to be doing? Are we going to do a show on this? And I think probably the best way to handle that, because it's so big, it's so complex, and has such a huge impact, I think the best way for us to handle that is we're probably going to do a series of shows and have different guests talk about the different pieces of the ACA and how they're going to handle it, how they're going to react to it. And that's just what we're going to do starting today with this show. So the ACA is law of the land, and just what does that mean for states? What is their best course of action? How should they respond? And that's exactly what we're going to talk about today. More specifically, we're going to talk about how one state plans to move ahead now that the court has ruled on Medicaid expansion. Tony Keck, Director at South Carolina Department of Health and Human Services, is going to be with us here in just a few minutes. He's going to talk about South Carolina's Medicaid plans and their approach to this issue and what they're going to be doing over the next several years. I think you're going to be very, very interested to hear what Tony has to say. I hope you're going to take some time to join us and be a participant in the show today as well. Also, in recognition of the popularity of Medicaid Matters, and I think also in recognition of the subject of today's show, we are being featured today on the Blog Talk Radio Network. Only a few shows a day achieve this status on the network, and we're very happy to be recognized as one of their top shows. Starting today. Hey, if you want to talk with me or if you want to talk with Tony during this show, there are several ways that you can be involved. One of the best ways, and probably the one that would be most interesting to other listeners and a way that you can get the most feedback and have a voice, is to give us a call. The lines are open now. You can call 626-657-2125. That's 627-2125, and you can speak with me, you can speak with Tony. We really want to have your comments and your thoughts on the subject as we're talking about this today as well. If you, for whatever reason, can't give us a call, you can also contact us on Twitter. You can get to us with our Twitter handle, which is @Medicaid Talks, and there's a comment or question through there. We're monitoring that, and we'll be happy to get that on the air as time permits. And finally, you can join a live chat that is going on right now. If you go to MedicaidTalk.com, if you're watching the show, you're right there already. You'll see it over in the over in the right-hand corner. Just join us there, and we'll read your comments or questions on the air again as time permits. Well, let's get to today's topic. I know this is going to be very interesting to our audience, and I hope some of you are going to jump in and talk with us. Joining us on today's show is Anthony Keck. Anthony likes to go by Tony, so that's what we're going to say and use during the show. Tony is Director of Health and Human Services for Governor Nikki Haley. He holds a bachelor's degree in industrial engineering and a master's of public health from the University of Michigan. And he's also completing his doctoral thesis in health systems management at Tulane University, focusing on physician workforce issues. Tony has over 23 years of experience in healthcare management, consulting, and policy. Prior to his appointment in South Carolina, he served in a similar capacity in the state of Louisiana, also as an advisor to the governor and chief of staff and deputy secretary of the Louisiana Department of Health and Human Services. So, Tony, welcome to Medicaid Matters.
Thanks, Richard. Glad to be here.
Well, we're certainly glad to have you. I know, as I said earlier, I think everyone is going to be interested to hear what you have to say. So, I thought because the next several shows that we do, in many ways, are going to be themed around the Supreme Court decision. I thought before we jump into specifics of what is happening in South Carolina and what the plans are there, I thought it'd be very interesting for our audience to hear your interpretation of the Supreme Court ruling and just very broadly the impact you think that's going to have on South Carolina.
Well, as you know, and probably most of your listeners know, South Carolina has been in the lead of opposing the Affordable Care Act, not because we don't share the goal of affordable access for everyone and improving health. It's really we don't agree with the means of doing it under Affordable Care Act, and so we're not happy that large parts of the law were upheld as constitutional. We don't really understand how hundreds of billions of subsidies can make health care more affordable, and when you look at what's happening in Massachusetts right now, I think the Massachusetts experience has borne that out. They're moving into a price control model because this major expansion that they did several years ago on their own really hasn't led to more affordable care. But the one part of the law that actually was a victory that for the 26 states that took it to the Supreme Court was related to the Medicaid expansion, and the court said that coercing the states by threatening their existing federal funding for their Medicaid program was unconstitutional, and so now this decision is back to the states, which is where most expansion decisions have been in the past, and I think that's proper. And I think we're going to see a lot of interesting conversations state by state that never happened before.
What do you think this means for states? And again, I don't want to jump into the specifics of Medicaid right now, but and I know that's a very big part of it. But what does this mean for states now that they have to now move forward and start to implement the provisions of the Affordable Care Act that were upheld by the court?
Well, I know in South Carolina, and really, as I talk to my fellow Medicaid directors and red states, blue states, it doesn't matter. Most people have been focusing on implementing the law. It's the law of the land, and the risks have been too high to just sort of bury your head in the sand and say, we're not going to participate or we're not going to plan for the myriad of new rules and regulations and systems that states have to put in place. So I think from a Medicaid perspective that every state has really been preparing for whatever's coming around the corner. And even in states that decide not to expand like ours, there still are a series of changes to Medicaid systems that were upheld as constitutional in the law, and we have to go ahead and make those changes. And so I think we're well positioned for that. I think outside of the Medicaid realm, employers were waiting to see what the Supreme Court was going to say, and so I think they're now moving very fast to make some decisions about how exchanges and how the new sets of penalties and taxes are going to affect them. And so I see a lot more employer movement than I did before the Supreme Court ruling. I think we've still got another question mark about what happens in November with the elections at the state level as well as congressional and presidential. And so there's still a pretty big period of uncertainty, but people are moving ahead. And I don't think, I think a lot of the changes which are happening right now really aren't necessarily in response to the Affordable Care Act. I think the Affordable Care Act was really a response to the fact that the nation reached a tipping point and states reached a tipping point and employers reached a tipping point where they realized that it was no longer possible to sustain the system's growth that has been growing at twice the rate of inflation for 30 or 40 years. And so you actually saw a lot of changes happening in providers, in employers, in states, and I think the fact that we didn't take care of it sooner enough or earlier really led to the Affordable Care Act. I think it was I don't want to call it a knee-jerk response, but I think it was a backlash against the fact that we had maybe moved too slow to reach that tipping point, and so the government stepped in, and now folks have a little bit of a hangover related to that.
I've heard some others in state government say that the Affordable Care Act had more to do with insurance reform than it did improving the quality of care, particularly as it relates to Medicaid members. Is that a position that you would agree with, or do you have another thought on that?
No, I think that's a good assessment. It's been a little frustrating to see the dialogue and see how the bill is structured, which essentially says all you have to do is give people an insurance card and subsidize their private insurance, give them a Medicaid card, and everything will turn out fine. If that was the case, the million people in South Carolina who are on Medicaid right now would, presumably be all perfectly healthy, but South Carolina is ranked 46 in the nation in terms of overall health. So it's a pretty tenuous proposition between health care insurance and health. And we're big believers in the social determinants model that health is 90% related to income, education, personal choices, genetics, and only 10% of it's really affected by health services. And so from an improving health perspective, the Affordable Care Act really puts a whole lot of money in the wrong area. From a policy reform perspective, it uses as a really a scapegoat, I think, the insurance industry as a target for reform. And certainly, look, I manage contracts, large contracts with insurers who deliver Medicaid managed care, and so I certainly know that there's plenty of opportunities for the insurance industry to improve. But if you look at the numbers in terms of where the money is being spent nationally, if you look at national healthcare expenditures, 90+% of the money is spent on the delivery system, and 6 or 7% of it is spent on insurance and in administration and so on. And so the bill is targeted towards reforming that 6-7% when what really needs to happen is the delivery system needs to be reformed. That's where 90% of the dollars are being spent, and that's where really people's health is most affected. So.
Mm-hmm. Now, we probably should let our audience know also that you're not just speaking from your experiences in Louisiana and South Carolina, but you're also very involved in the state Medicaid Directors Association. Is that correct?
Yeah, that's a fairly new organization, about a year and a half old, so I've been active in that. I recently filled a vacancy on the board for the southern region, and so that's been a really useful forum, I think, for all of us to talk about policy, to share operational stories and strategies, and they're just doing a great job. Matt Sallow and his team are, I think, really representing Medicaid directors very well up in Washington, and really it's about time. I mean, it's frustrating to watch TV news shows and read in the paper all sorts of folks talking about Medicaid expansion, and very rarely until recently have they talked to Medicaid directors about it. Some of whom have been doing it for 15, 20 years, and some who are brand new to it, like me. And so that's one of the reasons I appreciate your show, because I think good policy, if you can't implement it, is just an opinion. And so where the rubber meets the road is how all of this is getting implemented. And I think where a lot of the innovation is occurring is at the state level, in state Medicaid agencies, in state hospital associations and medical societies. It's not at the federal level in a 2,000-page bill.
Mm-hmm. Well, what do you think are going to be some, and we just have just a minute or here before we go to the break, but what do you think are going to be some of the priorities for South Carolina as far as your Medicaid program?
Well, like I said, we really believe in the social determinants model, and so the charge that brings to the Medicaid agency is to make sure that we're not sucking up every single new state general fund dollar that comes into the state. We've revamped our mission to state that we want to purchase the most health at the least cost for our citizens in need. And it's a very different philosophy from just being a payer of claims. It recognizes that our goal needs to be health, not just health services, but health, and that we have to make tough choices about who and what to spend our limited money on. And so we're very focused on two things: reducing unit cost and improving unit outcomes. That's an increase in value. And so our major strategies are payment reform, clinical integration, working on hotspots of disparities. We should be working on where the problems are. And then market reform strategies such as transparency tools and looking at how we do graduate medical education and some workforce issues in South Carolina. So we can talk more about those as we go on, but that's our high-level strategy.
Well, like most states, you've got a full plate. There's no question about it.
Yeah, that's right. Some states have plates that are more full than ours.
Yeah, no doubt, no doubt. Well, we're going to take a short break here to hear from some of our sponsors. When we come back, we're going to still talk with Tony, of course. We're going to talk about things like payment reform. We're going to talk about what South Carolina is doing in that area and how something like block grants might affect the overall Medicaid landscape for South Carolina. And certainly, Tony, your perspective from the State Medicaid Directors Association on that issue would be very interesting as well. So we'll be back in just a few minutes.
Nurses who want to stay on top of their skills know that the Nursing Informatics Learning Center is the place to go. You'll find articles, tutorials, a blog, e-zine, board-approved CE credits, links, assessments, and consultant services, all available to the global nursing community in one place. If you're a nurse or if your organization employs nurses, you need to visit the Nursing Informatics Learning Center.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Listen to this letter to a Medicaid health plan that helped save the life of Juan, a 4-year-old with a rare heart disease.
All of your efforts have created a miracle for my son. Even though he was so close to death, you helped. You made a difference. Now he's coming along, little by little, step by step.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at mhpa.org.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new advanced care transitions program, companies can dramatically raise the quality of care without increasing their cost. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid health care. Did you know that people could actually listen to this show right from your company's website? It will promote you as a brand leader in the Medicaid health industry. It'll drive traffic to your site, and it's going to demonstrate your commitment to innovation in Medicaid health care. If you'd like more about this and how to get that done, just email us at info@medicaidservices.net. That's info@medicaidservices.net. And if you're at the MedicaidTalk.com webpage, or if you're watching the show there live right now, we're also conducting an audience survey, and we'd really like to get your input. It takes less than 1 minute to complete this survey. You can just click on that survey box that's down below the viewing screen, and we can get your comments. It will help us keep the show relevant and timely, and your help would be greatly appreciated. Well, there are many challenges to Medicaid today, and today we're learning about how one state, South Carolina, is responding to those challenges. We're talking with Tony Keck, Director at South Carolina Department of Health and Human Services. Hey, Tony, during the break, an interesting question came in through our chat line that actually I was going to plan to ask you about later in the show, but I want to go ahead and ask it now since the subject is kind of fresh. They're asking you to expand on the 10% of health outcomes that are related to health services. I know you're talking about the 90% being a more of a social determination model, but expand a little bit on the 10%.
Well, again, I think as much as you do to keep people healthy, and as much as people do to keep themselves healthy, eventually you get sick. And most people at some point in their life will experience some sort of illness. And so the health system needs to be able to respond to that. The question is the health system that we have today effectively responding to that? And I think from all the research I've seen, the answer is no. The Institute of Medicine, about a year and a half ago now, put together a report on cost in healthcare, and they have roundtables on value-driven healthcare. And the roundtable produced a 900-page report on its discussions and its findings. And they determined, similar to other research over the years, that about a third of all healthcare spending is actually excess cost. And so, although we're putting large amounts of money into healthcare, and again, it's growing at twice the rate of inflation for many, many years, and now is becoming the single biggest budget item in most states' budgets, and it's becoming one of the largest items in many employers' budgets. A lot of that spending is simply excess cost that does nothing to improve healthcare, and we see that everywhere. I could give you lots of very specific examples where we implement new management controls, new means of analysis, new programs, and find significant excess cost in our own Medicaid program that has always just been there, and nobody's ever just rooted it out. So we consider that a very important component of what we're trying to do, is to lower that unit cost of healthcare. And then coverage will be more affordable if healthcare is cheaper, and it'll also give us more money to put into the social determinant side as a state. If I can save money on the Medicaid side, some of that money could be freed up to go to education, to roads, to what the legislature decides is a priority.
Well, you mentioned lowering the unit cost, and that's a great segue into the next area I wanted to ask you about, because I know you have been active and working on payment reform. Tell us a little bit about your approach to this.
Harold Miller at the Center for Healthcare Quality and Payment Reform really has influenced a lot of our thinking on this. And he emphasizes two things. First, control and reward for care management needs to shift from health plans more into the hands of providers. So this is really where the magic is happening. There's a great example of Greenville Hospital System up in the upstate portion of South Carolina, where by redesigning some of their care systems in one of their internal medicine clinics for Medicaid patients, they were able to reduce hospitalizations by 50%. They were able to reduce emergency room visits by 25%, and they were able to increase clinical measures of success in every case. And so care management, I believe, and I think a lot of the research shows, is most effective at the provider level. The second thing is that payers need to meet providers where they're at. And so there's no one-size-fits-all approach, and I think this is one of the weaknesses of federal efforts through Medicare and so on, is that different providers, different types of providers have different capabilities to assume risk, to do more of this care management. And you have to be able to go provider by provider to figure out what's the most effective way to get incentives aligned with this provider to lower costs and improve care. So those are two things that are very important to us. And a couple of the ways that we're operationalizing that is, one, we've joined a national group called Catalyst for Payment Reform, following the lead of Ohio Medicaid. We're the second Medicaid agency to join this group made up of large employers like GE and Boeing and Walmart. And this group has committed to adopting model contract language into their health plan contracts, which require movement towards changing how we pay providers. And they have a goal of 20% of all payments made have to be value-based payments by 2020. We probably will move a fair amount faster than that in South Carolina.
Well, the subject, whenever we talk about payment reform or payment reimbursements, whatever it might be, the subject of block grants has to come into the equation. And again, it's really going to depend, I know, a lot on what happens in the elections in November, who retains or gets control of Congress, all that. But I know block grants is on the drawing board, and I'm curious as to what you think that kind of impact would have on South Carolina.
We're big proponents of block grants. It's essentially how we pay our managed care plans right now in a capitated manner, and we determine a price for the care on a per member per month basis. You multiply that by the number of people who are eligible for services, and then the health plan is at risk for delivering those services. And when you structure a set of expectations and quality measurements and incentives and withholds to make sure that you have an adequate network, to make sure that kids are getting their recommended screenings, it aligns the incentives for that health plan to perform. And so if you take that idea that is very widespread throughout all the states, red states or blue states, it doesn't matter, and you take it up a level and say, well, why wouldn't we do the same thing for states and essentially capitate them? We propose a model of what we call accountable block grants, where there's a set amount of money that varies according to a set inflationary amount that is tied into general inflation, that grows with population growth, but gives the state a lot of flexibility on how to spend the money to achieve a set of negotiated outcomes with the federal government. The sad truth is right now is for all the money that the feds send down here, they never ask us to really improve health. They just ask us to make sure that we follow 10,000 rules related to accounting for the dollars. Mm-hmm. They've never had a conversation with us about lowering the rate of childhood obesity or closing the disparities between mortality for breast cancer between African American women and white women. We never have those conversations. And so we think that if given the opportunity to spend the money in a much more flexible way, spend it where we need it on the types of services that we need it, we'd be more than willing to agree with the federal government to meet these types of targets and actually have incentives and penalties tied to those targets. And I think the power of that is that it then gets the entire state behind achieving these goals. And if our legislature knew that we could potentially be penalized if we didn't meet our reducing childhood obesity goal, for instance, they would go much beyond the typical medical model of trying to provide health services to meet that goal. They would most likely get into education and think about physical education in the workforce. They might think about the built environment and how we encourage kids and adults to get out and play and walk more. And so I think it gives a much more, it aligns incentives much more holistically beyond just the typical health services model to actually achieve better health.
Well, that's a very good argument for block grants. I know there's a lot of resistance to it. Where do you think that resistance comes from?
Well, I think there's some fear that states are going to do the wrong thing. And there's a lot of people who don't trust states to do the right thing. Having been in government for a few years now, but having been in the private sector for many more years beyond that, I think that's ludicrous. I mean, most of the innovations have come at the state level. And Medicaid directors and governors and state legislators are in constant contact every day with individuals who have serious needs, who have healthcare needs, who've lost their jobs, with business people who are experiencing high costs. And so we're close to those individuals on a daily basis. I get letters on a daily basis asking me to help out with business situations or individuals' health situations.
Tony, we're going to have to I'm going to have you hold that thought because we're going to run to a break here. And when we get back, we're going to talk about that and about exchanges. So we'll stay with us. We'll be right back.
Medicaid Matters is now booking guests. Who are we looking for? We're looking for people who can bring a fresh and unique perspective to the business of Medicaid health care. Do you have an idea that is unique, innovative, maybe even controversial? We want to hear from you. Go to MedicaidTalk.com, complete our guest questionnaire, and we'll be in touch with you to schedule an upcoming episode. Be a part of Medicaid Talk.
The Medicaid landscape is changing fast, and that means challenges, but it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
You're listening to Medicaid Matters on the blogtalkradio.com network.
And welcome back to Medicaid Matters. Hey, how would you like to be able to bring your message to over thousands of Medicaid professionals? Well, by being a sponsor of the Medicaid Matters talk show, you can do just that. Email us at info@medicaidservices.net. You can get more information about joining the Medicaid Talk community and being a supporter of this program. You know, at the end of this month, Medicaid Matters will be broadcasting live from the Medicaid Enterprise Systems Conference in Boston, Massachusetts. I believe our broadcast is scheduled for August 21st. It'll be a special 2-hour broadcast. This is a conference that was formerly known as the MMIS Conference, and it is the conference for MMIS professionals, bringing together thought leaders from both the public and private sectors. They'll be there to share ideas. There'll be many, many presentations and information related to Medicaid systems and initiatives. If you can go to MedicaidTalk.com, you'll see a link to the conference, and we hope that if you do go, you'll be able to drop by our broadcast booth and say hello. I believe it will be broadcasting live August 21st from 1 to 3 p.m. Eastern Time, and we're going to be talking with not only the conference organizers, but many of the presenters, many of the people who are going to be bringing new ideas and thoughts. So make plans now to be listening or watching Medicaid Matters on August 21st. Tony, I'm sorry I had to cut you off there to get to that series of messages, but would you go ahead and finish your thought on the block grant thing that you were talking about?
Sure. I think that, one of the reasons that there's a group of folks who are opposed to block grants is because they just don't trust the states. And as I said, I think that's really just unjustified. But I also think that there's a lot of folks who benefit financially from an open-ended program, and so we shouldn't be Pollyannish about the fact that healthcare is the biggest industry in the United States, and there's a lot of powerful forces who don't want to see controls on the program.
Mm-hmm. Well, now that Affordable Care Act has been settled at least until November, I know there's a lot of speculation that there could be a lot of undoing of what the Supreme Court ruled on after November. But what is South Carolina going to be doing with respect to the exchanges?
We were one of the first states to publish our findings from a 6-month analysis of a group of independent stakeholders. And we recommended that we not pursue a state-based exchange. And the rationale behind that was really based on a few things. One, exchanges as they're envisioned in the law are primarily ways to deliver the federal premium subsidies. And that is almost exclusively a federally managed program, and so there's really no compelling. I think we also thought that exchanges were going to take us off track from focusing on our primary mission of improving health. And there are very good arguments for staying focused on only a few things. Every single Medicaid agency's bandwidth is being challenged right now.
Mm-hmm.
And if we had to drop everything to work on exchanges like many states have suggested they're going to do, we just didn't think that we could get everything done that we needed to do. And the feds have said, we'll do it. So we said, okay, go ahead and do it. I think also, our analysis showed that states would really have very little flexibility under the concept of state-based exchange. And so we'd really just be an extension of the federal government policy anyways.
Mm-hmm.
And then finally, if we don't like it, after a year we can apply to take it back. So it just doesn't make a lot of sense for us, and we don't think it makes a lot of sense for other states to jump into this. And where we got a lot of criticism since we were one of the first states out there to point this out, now I think you see that there's about 35 states who are waiting.
Mm-hmm. Well, what's the alternative then? What is South Carolina going to do instead of an exchange?
Well, the federal exchange will still operate.
Mm-hmm.
And so states that choose not to do a state-based exchange, if the feds meet their commitments, every state will have an exchange operating.
Mm-hmm.
And so it's really not an either-or. It's who was going to spend their time doing it. And we just thought, again, because it was primarily a vehicle for delivering these federal tax subsidies on premiums, that it didn't make sense for us to get involved in it.
How many other states are taking the same course of action? Approximately, just off the top of your head.
Well, I think what you see right now is there's only 10, 12, 15 states who have said for sure that they're going to go ahead and do a state-based exchange. Mm-hmm. I think there's 12, 15 who said they're absolutely not going to do it, and you've got a whole range of folks that are in between and waiting essentially for the election. But all of those folks who are waiting, I don't think that the time exists for them to actually jump in and do their own state-based exchange. So, again, I think most states, the vast majority, are going to let the feds do it.
I think I understand why South Carolina is not going to pursue the state-based exchanges, but is there any scenario where it would make sense for a state to do that?
I don't really think so. It again, the law is primarily designed to deliver the federal subsidies for insurance. And so the part of the exchange law that produces a marketplace for people to get online, compare insurance prices, quality, and so on, everybody agrees that that's a smart thing. But that's just a very, very small component of the law. The law is primarily set up to do eligibility determinations for people about what types of subsidy they're going to get. And so why a state would want to get involved in that process, which is no different than, for instance, the federal government running the Social Security office.
Mm-hmm.
It just doesn't make sense to us that a state would want to divert a lot of time and attention and money at considerable risk to doing something that really the federal government should be doing.
How have providers in South Carolina reacted to this decision?
Related to exchanges?
Yeah, related to exchanges.
I think, most of our providers, I know, for instance, for physicians, they believe a lot of these subsidies are not a smart idea, and they see it as a way that the government is just going to have more and more control over healthcare. And again, I think if you look at Massachusetts, now they're moving into a price control model, and I think physicians around the country are very fearful of that. Data has recently come out that said a third of physicians last year wouldn't take new Medicaid patients, which is about double for other types of insurance.
Mm-hmm.
And so the physician community is, in general, opposed to the Affordable Care Act. Hospitals, I haven't got much pushback at all about the exchange decision. Insurers, they would prefer that the state run their own exchange, but they just think that it would be administratively more simple. But we haven't got much pushback from our local insurers either.
Okay. I just want to jump back real quick to the payment questions we were going, or the payment reform subjects that we were talking about earlier.
Sure.
Yeah, a lot of states have responded to the reduced funding into their budget from tax revenue or just general reduced revenue coming into the state budget by either eliminating people that would have otherwise had been eligible for Medicaid, or they're cutting reimbursements, and a lot of that is going on around the country. How has South Carolina reacted to the state budgeting issues?
Well, when we came in about a year and a half ago, we had a $228 million mid-year state general fund deficit in Medicaid. And part of the problem was bad budgeting, and part of the problem was that state law prohibited us from making any rate adjustments for the prior 3 years.
Mm-hmm.
And so we had to tackle that. We got the law revoked, and we made some rate adjustments. But we told our providers, look, this is, anybody can just cut rates. You need a calculator and a pencil and a pad of paper. That's not health reform.
Mm-hmm.
And health reform is actually getting that excess cost out of the system that's due to unnecessary services, administrative waste, inefficient services, to some extent too high a price. But the real cost savings come elsewhere. And so we've entered into a partnership with our hospital association, with our nursing home association, to really focus on getting costs out of the system in these areas and not cutting rates. The legislature has responded well to that.
Mm-hmm.
When they see the Medicaid agency working with hospitals, working with nursing homes, doctors, and Blue Cross Blue Shield, I think that they believe that we are getting this program on a sustainable path, and they have been willing to actually make investments in the program over the past year and a half. And so this year, while lots of states are cutting, we actually put new money into the Medicaid program so that we would be meeting the commitments that we have made. So now next year, we're going to be in a little bit different situation. We're going to just natural growth in the program without any expansion and without me taking any policy action is going to be around $150 million to $200 million in state general fund next year. That's almost every single new state general fund dollar projected by our Bureau of Economic Analysis. And so the legislature is not going to let that happen,
right?
Neither Republicans nor Democrats. And so we're going to have to go forward with a plan with the providers to say, where are we going to get this extra money? And the conversations I've had to date already have identified some really important areas where we can get that cost out. We got a lot of cost variation in hospital prices between hospitals. We probably have a fair amount of unnecessary services that are being done. And hospitals and other healthcare providers understand this. And so they just want some predictability about how we're going to get that cost out of the system.
Okay, well, we're going to take our last break here for just a few minutes, and then we're going to finish our conversation with Tony Keck, who is director at South Carolina Department of Health and Human Services. So just hold on for a few minutes, and we'll be right back.
I hope you're enjoying today's show, and I want to remind you that opinions and viewpoints expressed by guests on the Medicaid Matters Talk Show are not necessarily those of the host or our sponsors. Thanks for listening, and we'll be back in just a moment.
Every 19 seconds, a child will die because of a lack of clean water. It is estimated that more than 80% of childhood diseases and deaths in underdeveloped countries are a direct result of drinking contaminated water. During the course of this commercial, 3 children will die. You can help make a difference in the lives of these children. By supporting Healing Hands International, you will provide safe, clean drinking water to families and villages around the world. Since 2006, Healing Hands has drilled more than 400 water wells in countries like Haiti, Ethiopia, Zimbabwe, and Honduras. Through the help of people like you, we have been able to bring the gift of clean water to more than 1 million people. To learn more about Healing Hands International and what we are doing to help, visit www.hhi.org. With your help, we can continue this life-saving work and make a significant difference in the lives of children.
And this is Medicaid Matters, the only business talk show about the Medicaid health care. We're here live every other Tuesday, 1 p.m. Eastern Time. So please make plans well, I guess it's every other week, to join us here for our live broadcast. You can also get archived broadcasts from the MedicaidTalk.com show page. You can get them from blogtalkradio.com/Medicaid Matters. And also, if you subscribe to Medicaid Matters on iTunes, those can be downloaded right to your iTunes player on a regular basis. You can listen to any shows that you miss there. Always better, though, to be here live because you can participate in the show. If you're on the MedicaidTalk.com show page, I know many of you are watching the show from there right now, you'll see next to the viewer a list of our sponsors, and one of those is Healing Hands International. We're helping Healing Hands to raise $40,000 before the end of the year, and I want to invite you to join this campaign to bring clean, healthy water to underdeveloped parts of the world. My company, Managed Medicaid Services, has set a goal of building 100 wells around the world. If you're in any way concerned about health care in underdeveloped countries, this is a very easy way to improve health by just providing something we take for granted very much here in the States, clean drinking water. So you can be a part of this effort. Join us in being a contributor to that program. Well, Tony, I want to, here in the final segment of the show, I want to ask you a few questions about the managed care model. I know South Carolina has used a managed care model for several years. Our company has been involved with several of the companies that are part of that program. How do you think your managed care model is going to have to change, though, over the next several years?
Well, we're moving from a growth strategy to a performance strategy. And so right now we have about 650,000 people in managed care, and we run a dual model. One model is a capitated model, and we have 4 plans that deliver capitated managed care. But we also have 3 plans that operate under a medical home network, which is essentially fee-for-service with a care management fee laid over top of it to the medical home network that they share with their physicians. And at the end of each quarter, we do a shared savings calculation, and we share that with the medical home network, and they share that with their doctor. We're working towards a major revamp of that to create a hybrid model, because there's advantages of both models. Under capitation, you can align incentives across different sectors of the healthcare industry. And so if I'm a doctor who can do something that saves $50,000 on the hospital side, right now in fee-for-service, it's very hard to reward that. Mm-hmm. But under a capitated model, it's much easier. At the same time, on the medical home network side, this focus on care management and sharing savings with doctors and paying a robust care management fee is something that we think is producing a lot of good results. And so we're going to do a major restructuring for 2014, which combines those 2 models. And capitated plans requires that they use a medical home network approach to care management and sharing reward with providers. In this recent contract year, we've made some short-term significant changes that other states have already made, but we've put in a robust incentive and withhold program. Mm-hmm. The withholds are tied to HEDIS measures. It's 1% of the overall payment managed care plans, and so it's a significant amount of money. They have to show a set amount of improvement over time, and they can't go below a certain floor, or that money's not paid back. On the incentive side, we are focusing on recognition for patient-centered medical homes and improving birth outcomes, and 75% of those incentives have to flow through to the provider. Mm-hmm. And so that's a pretty significant change in the short term, but longer term is really where we think we're going to put a lot of energy to create this new model that, again, is based on that idea that we need to get much more care management into the hands of providers instead of doing it at a higher level at a computer terminal in Omaha somewhere. Mm-hmm.
Mm-hmm. Can you share with us any specific health outcomes you're hoping to achieve by implementing this change?
Well, the biggest is that we've identified as a key target and built into all of our balanced scorecards is our birth outcome initiative. And South Carolina has one of the highest rates of mortality and one of the highest rates of prematurity in the country. And we think that there are solutions that can be implemented through the healthcare services side of the equation to actually reduce prematurity and reduce infant mortality. And so we're very focused on ending early elective deliveries in partnership with the Market Dimes and the local hospital association and obstetricians. We're very focused on identifying and treating substance abuse in pregnant women, which is an increasing problem, especially prescription drug abuse. And so we've instituted payments for screening of these women and then connecting them to treatment networks. So we're very, very focused on birth outcomes. Mm-hmm. There's certainly other areas, especially as more and more adults come on to the program, related to obesity and all of its comorbidities. And I think the next several months you'll see some initiatives similar to our birth outcomes initiative to try to address obesity and diabetes
You mentioned something there about the March of Dimes I want to ask you about, because I'm hearing from a lot of Medicaid health plans about a greater use of integrating community resources to not just do care management, but to provide care, to engage members. How is the state of South Carolina, how is the state working with community resources that maybe nonprofits that aren't affiliated with the state to integrate them into this new model?
That's a great question. I think we're doing two things related to that. One is we have a very successful centering program up in Greenville at a OB clinic that deals largely with Medicaid women and does 6,000 or 7,000 deliveries a year. A centering program is essentially a group prenatal program, and the pregnant women, deliver a lot of care and counseling to themselves. Mm-hmm. And there was recently a journal article about this experience that showed prematurity was reduced by almost half in the population. So we are partnering with Greenville to help spread this model out to the rest of the state through our managed care. Mm-hmm. I think the other thing we're doing is working with the plans. We're investing in community health workers. And we recognize there are many, many people that are members of churches right now, that are working in schools, that are working in nonprofits and organizations, who are trusted members of a community who can help deliver healthcare counseling, can help ensure that people are taking their medications, that they're getting their screening. And there are models nationwide of how you train these community health workers and then how you reimburse for them. And mm-hmm. So we're within a few months of putting our proposal out on the street. We're working with a local technical community college, our University of South Carolina, and some other organizations to get these community health workers to market.
Well, other than what we've discussed, we just have a few minutes left here, Tony. What else is on the agenda for South Carolina Medicaid?
Well, I think I made a reference to a couple things, but and as you said, every Medicaid agency is pretty busy right now, mm-hmm. not overwhelmed. But a couple things that we're working on. One, I'm very proud of. We're trying to become a highly reliable organization ourselves. And as we push on the provider community to do better, we have to be a better payer. And so we're spending lots of time trying to figure out how to reduce cancel factors for providers. And a lot of this has to do with claims payment. A lot of it has to do with prior authorization. And about 9 months ago, we started an internal Six Sigma program, and we now have 60 people in the organization that are Six Sigma trained, mm-hmm. process improvement trained. About 30 of them are certified as Green Belt, and they are going system by system trying to figure out how to make us a better payer and how to reduce hazard factors for doctors. So that's one thing I'm very proud about. I think we're doing a lot of interest.
90 seconds.
We want to make sure that for the $200 million that we spend a year on graduate medical education, that we're actually getting what we pay for. Mm-hmm. Very frustrating that we still have so many shortage areas in the state. We're paying so much money to train doctors, and so we're partnering with our major teaching institutions to address that. So that's just one more thing that's not just Medicaid specific, but we're
60 seconds.
Well, a lot on the plate. And Tony, I appreciate you taking some time to be with us today. Thanks very much.
Well, I appreciate it. It's a great show, and keep up the good work.
Thanks, and I'm sure we'll want to talk to you again in the future. That was Tony Keck, Director at South Carolina Department of Health and Human Services. Hey, if you want to get updates about upcoming shows, you need to register for those notices at our blog. You can do it right there at MedicaidTalk.com. And take our audience surveys while you have a moment. Just click on the icon that's below the video screen, and that will help us keep our programming relevant and timely for you. And don't forget, we're going to be broadcasting live from the Medicaid Enterprise Systems Conference in Boston at the end of the month. We hope we see you there. And you've been
10
listening
seconds.
to Medicaid Matters, brought to you by Managed Medicaid Services. Today is Tuesday, August 7th, 2012, and we'll be talking again in 2 weeks. Have a great day.